EMDownload.com presents Biliary Tract Ultrasound by myself, Diku Mandavia. This is part of a series of ultrasound talks. We're going to concentrate on the right upper quadrant, so sit back and enjoy.
Okay, now let's switch to abdominal ultrasound. Obviously, ultrasound is a very important modality in abdominal pain. We're using it on a regular basis and have been doing so for a long time. And there's a lot of these indications that I think we can do ourselves. So we're going to talk about some of these now. I'm going to talk about biliary tract disease, and I'm also going to talk to you about the aorta. A little later, we're going to discuss the kidney. We're also going to talk about the pelvis a little bit later. And Dr. Swadron will come in and talk about abdominal trauma. So let's now focus just on the right upper quadrant and as well the abdominal aorta. Okay, so who are we going to scan as far as the right upper quadrant? Well, anyone that we suspect biliary colic or cholecystitis, and that's going to be a clinical judgment. Who do you think? One of the things I would warn you, you don't want to use your ultrasound and just go hunting for causes of abdominal pain and look around, because you will obviously find gallstones in a large percentage of patients, but that doesn't mean your patient has biliary colic or cholecystitis today. So we're going to go in, we're going to have the clinical background, the scenario behind us, and that's really powerful. You know, when we're actually interpreting our images, we can sort of remove extraneous data and look at the data points that are most relevant. Obviously, patients with pancreatitis, we know that gallstone pancreatitis is a big cause of pancreatitis, and therefore we want to scan those patients. We do have alternate investigations. We have HIDA-scan, which is a great scan for function. Fortunately, it takes time. It's really not that much an emergency sort of an imaging modality. And CT as well. We're using CT every day for a lot of indications. But still, CT is not the best for the right upper quadrant. So let's talk a little bit about the anatomy, because you really need to know some parts of this critical anatomy. Well, this is a Netter drawing. Actually, let me just go back. Sorry. This is a Netter drawing that we're looking at. And we have the gallbladder here. And we have the gallbladder is going to taper down to the cystic duct. And it's going to be joined by the hepatic duct. And together they're going to form the common bile duct. And they're going to sit adjacent to the hepatic artery and the portal vein. And that's actually a portal triad down there. So this is the area that we're scanning, the entire gallbladder, right on down to basically the bile duct. This is the biliary tree that we're going to scan. And this is a good illustration showing different ways the gallbladder can lie in different patients. And this is a good schematic explaining why when we palpate someone's abdomen, we say, oh, he's got a Murphy sign. We actually really don't know if what we're palpating on is truly the gallbladder. You know, gallbladder could be far right lateral, it could be more mid-epigastric, it could be where it's supposed to be. But it will be all over the place, and that's why a sonographic Murphy's is so much more helpful when you're scanning a patient. So what are we going to use? Well, I already told you that 3.5 megahertz is jack of all trades. So a 3.5 megahertz probe would be a great place to start. And you want to position your patient so left lateral decubitus is the ideal position. And if you do that, you're going to have a relatively good long axis view of the gallbladder, and you're going to be able to see first if they have gallstone and sonographic Murphy's. As you get really good at this, you'll start detecting wall thickening and bile duct dilatation. Okay, so I consider those a little bit more advanced. But if you can at least see, hey, does the patient have gallstones, yes or no, and is it tender when I'm palpating, that's, to me, important data points. So here's someone that we're scanning right now, and we've got him turned to the left lateral decubitus. And I want to point out how we're scanning him. First thing is the marker that you're going to see, and the marker is right up here at the top, okay? This is the marker right there. There's a little dot right there. That's pointing right now to the right shoulder. Okay? Basically, if you draw a line along the costal margin, which will go this way, this is a dot right here. That's the dot. If you go perpendicular to the costal margin with the marker to the right shoulder, almost all the time you'll get a pretty good view of the gallbladder. That's a great place to start. You really need to position your patient, turn to the left lateral decubitus, and you'll scan subcostally, and you'll also scan intercostally. So you'll go a little more cephalad and go through those ribs and see what you're seeing. Okay, so the first thing is you find the gallbladder using that position that we just went through, and then you will see, does the patient have a gallstone? Yes or no? And what really defines a gallstone? Well, it's going to be a hyperechoic area sitting in the gallbladder, and it's going to shadow. Now, stones usually are mobile, so if you actually were to turn the patient and rescan again, it would move slightly. Or, obviously, if it's an inflamed gallbladder, a stone stuck at a gallbladder neck, it wouldn't move. But they definitely need to be sitting in the gallbladder, and they need to cast a shadow. Because there's a lot of mimics in the right upper quadrant. And I'll tell you right now, the gallbladder is probably the most difficult study that we will do. No doubt in my mind. It's the most difficult study. Because there's a lot of pitfalls in the right upper quadrant, including simple abdominal gas. And gas is really your enemy in ultrasound. It causes difficulty in scanning, and it'll cause shadows. And if you don't know definitely you're in a gallbladder and you see the shadow, you think this is a gallstone, you'll make a mistake. So you want to make sure you're seeing the gallbladder, and then do they have a stone within it. So here's that left lateral decubitus position that we're going to put that patient. It's called a Kazan position. Ideally, you'd want to have this right arm here, up above the head, because when you do that, the ribs will spread apart a little bit. Okay, and then this is this line that we're seeing here is cutting. This is a costal margin here, and we're cutting perpendicular to the costal margin. So that's the ideal place to initially start scanning your patient. And this is a schematic of what a gallstone looks like. And if you look at this carefully, you'll understand why God really made the right upper quadrant to be scanned. And if you take a look at this right upper quadrant, first thing, in the first day, he put the liver on the right side of the body. And he made it large, and he encapsulated the gallbladder with the liver, more or less. And the liver provides a great acoustic window. On the second day, he actually filled the gallbladder with fluid. He put the bile in the gallbladder, and when you actually have this fluid tissue interface, you'll get great ultrasound images. And that's why every indication that we do in ultrasound has, or more or less, will have a fluid tissue interface. And those will be the best indications, at least. And then on the last day, he made the pathology echogenic. Okay, so we have all the characteristics of a great ultrasound in the right upper quadrant, and that's why still today the ultrasound is the best modality to scan and to image the right upper quadrant. So here's some other images now of the right upper quadrant. We have multiple stones with shadows here on the left side, and we have a schematic showing that as well. And again, we have multiple stones here. We have the gallbladder, which again, anechoic, and lots of shadows. Yeah, you can roll them. You can roll them and see if that'll move. Now remember, if a stone is stuck and inflamed, it's going to cause a problem, and it's not going to move at all. Actually, I'm going to stop right here for 1 second because I believe those guys are walking out. Did everyone get a parking pass validation? No? I want to make sure before those guys. The gallbladder, multiple stones, multiple shadows. This is a pretty classic sort of example. Okay, so here's another patient that we're scanning, right upper quadrant. Here's our gallbladder. And then, boom, there's a large stone there. Large stone at the neck of the gallbladder. Then there's also something that does come into view occasionally, and this is the portal vein right down here. Portal vein is right here. Okay? This is actually what's called the exclamation sign, the gallbladder being the long part of exclamation, the portal vein being the dot. Okay? And so this stone is down toward the neck of the gallbladder. Here's another one. Neck of the gallbladder here. Big shadow. And stones will look different. So this is another patient that we're scanning. and this patient has multiple large stones, and we can do a long axis to the gallbladder, and then we can turn our probe and do a shorter axis of the gallbladder. And we can see the stone clearly. It's hyperechoic. It's got a nice clean shadow.
What's the relation to the last meal?
Yeah, you'd want, obviously, if a patient has, the question is, what's the relation to the last meal? Basically, if they've just eaten, obviously a fatty food especially, the gallbladder is contracted usually, and the gallbladder will be difficult to visualize. Now, with that said, most of our patients with true abdominal pain are MPO, not eaten at least for a few hours, and you can scan them. You can scan them. But obviously for outpatient scanning, a radiologist would want them MPO. Here's a patient that we scanned. This is the right upper quadrant. You can see the gallbladder. You can see a large stone right here. But I also want to show you the wall here. See this wall here? This is the gallbladder wall. It's about, more than a centimeter thick. Okay, this is a very inflamed gallbladder wall. This is actually a patient with cholecystitis. So when you have a really edematous gallbladder, inflamed gallbladder, the wall will thicken.
What is the criteria for wall thickening?
The criteria for wall thickening, anything about 3 to 4 millimeters would be considered a thickened wall. And sometimes you also see fluid within the wall or fluid around the wall, and that's called pericholecystic fluid. Those will also be signs of cholecystitis.
Point out the liver edge that you're using to use the marker.
Okay, the edges of the gallbladder edges, one here would be, this would be one edge, and this would be the other edge. And you always measure the proximal wall. This is a video clip of that same patient. Okay, so we are looking now at, we see the gallstone. But take a look at that gallbladder. You can see that the wall is thick. And actually at the bottom part of the screen, right here, you can actually see fluid. That's pericholecystic fluid right here. Okay, so that's another sign of cholecystitis. Remember, we have the white count and a fever, the temperature. Those things aren't going to be sensitive or specific enough. So gallbladder ultrasound can provide a lot more information. It's a lot more specific. Here's a case that was seen at USC, and one of the residents marked this down on the image and submitted it into our logbook. And he has correctly identified the gallbladder, but then he wrote down, he annotated this by saying it's a gallstone. And he was looking at this hyperechoic area and this shadow. Does this fit the criteria that we just went over? Remember, the first thing is this stone has to lie in the gallbladder. This is a bowel shadow. This is a bowel shadow. This is not a gallstone. Okay? Remember, it has to lie in the gallbladder. Okay, so again, this is one of the mimics in the right upper quadrant, one of the reasons why it can be difficult to evaluate.
What is bowel?
Bowel will be, we're going to see it tomorrow in the lab, but it's going to be indiscreet. It's going to be very difficult to image. Bowel is full of air. You just don't see anything, basically. Occasionally, you'll see peristalsis if there's fluid within the bowel. Here's a patient, gallbladder that we're looking at, who has edge artifact. You look on the edge of that gallbladder, you see a very small shadow. Okay? We don't want to call that a gallstone. This is edge artifact. Okay, so remember, you want to be able, first, we also don't see a hyperechoic area. So if you did think that was maybe a small stone, turn the patient or turn the probe and angle from a different location. Here's another patient that we're scanning, the right upper quadrant. We've found the gallbladder. Question is this a gallstone? Are these multiple gallstones? What do you guys think? No. No shadow. So it does not meet criteria. Now, I will also tell you that when you look at this area, that there's some areas that look almost polypoid. These are actually gallbladder polyps. Okay, but I will warn you right now, if you start seeing things like this, these are things that are going to really be outside of our scope. Because I'm not going to really go over, we don't want to be taking the risk of, is this cholangiocarcinoma or is this a gallbladder polyp? Let someone else take that risk. Let the radiologist sort that one out. So if you got a case like this, just order a formal study. Yeah, question?
Do you not call that sludge?
No, sludge, this is not sludge. Sludge will actually layer. Okay, so but you can see that we actually see that it's not layering here. But sludge will have the exact same consistency. This is a large hepatoma. As you start scanning, you're going to see patients that will have other causes of abdominal pain. And this is a liver, and this liver doesn't look like any other livers that I've shown you. Remember, liver is a homogeneous organ. It's going to be, it's not going to have hyperechoic areas and hypoechoic areas. It's going to look more or less smooth throughout. And this is a large hepatoma. So, some pitfalls. Abdominal gas. Remember, gas is your enemy. Chronic cholecystitis with a shrunken gallbladder, those can be difficult to find because the gallbladder is so tiny. Stones at the gallbladder neck, make sure you're scanning all the way down, scanning the whole gallbladder. And lastly, if the gallbladder is perforated from gangrene, you're not going to have any fluid. There's nothing to be really left to scan within that gallbladder. Now, obviously, that patient is going to be toxic. You're going to have a clinical awareness that something's wrong. You're going to get a CT, etc.